Good morning, everybody. This is Gabriele Jasper MD and Jeremy on the show today.
Doc couldn't hear that. I just gave you an applause.
Well, I can hear that. I heard it.
You did, yeah.
I can probably hear it coming out of there. All right, so we'll talk about some of the few things that we do at the interventional pain practice. I'm an MD. I'm a minimally invasive spine surgeon. I've studied. I did a residency in a preliminary in general surgery, anesthesia, intensive care. I majored a lot in the pediatric anesthesia and also interventional pain in my residency. It wasn't even called interventional pain.
Yeah,
it was pretty. It wasn't even barely in the evolution. It was the genesis of it.
right.
But now we're in the evolution and we're learning new stuff all the time. And just to let you know what we do as far as interventional pain, we look for the pain generator, we find it, and we get rid of it. And I hate to say it, but and I say this all the time, sometimes it's a process of elimination. It's no guesswork. People could have 5 generators causing the same kind of pain. So when you come to a doctor like me, you need to have patience, just like the doctor learns to have patience. You keep trying and you will succeed, especially if you don't do everything all at once.
Right.
You have to pick each pain generator individually. I remember I met at a conference a pain doctor when we used to get paid for each individual injections, even if you did them at the same time.
Right.
That I don't think happens anymore for good reason. And he says he gave an epidural injection. He did radio frequency lesioning for the patient, trigger point injections, and a couple other ones. And he said the patient was 100% pain free. I said, yeah, but how do you know where the pain generator is?
Right.
It don't matter. I just got rid of their pain. But that's a lot of steroid. That's a shotgun approach. It's not good medicine.
A lot of hope too.
Yeah. I mean, if you do that much, the patient's definitely going to feel better.
Oh, sure. Yeah.
But you're better off having a patient 50% better. And then now you know that 50% of the pain is coming from that particular pain generator.
Right.
And then you look for another one. And then the other one might be 25%.
Yeah.
And now you can exclude based on their symptoms where the pain's coming from. It's diagnosis. You have diagnostic injections and therapeutic. You just bombard them with all kinds of steroid, they're going to feel 10 years younger.
Right.
But that's not necessarily good for you. We have a couple topics. I'm probably considered the master of the spine, master especially of the lumbar.
Oh, without a doubt.
The lumbar spine is pretty easy for me to take care of. There's not much there that I can't fix. When I say fix, of course, when you have a bad back, you're always going to have a bad back. Just, give you a good quality of life. And a lot of times you just get rid of the pain, sometimes indefinitely.
Right.
It's rare, but you could do it. If it's a young person, one isolated herniated disc, you take that out and the pain goes away. Could be forever. But why did he herniate or she herniate? It could have been a trauma. But that disc now is never going to be the same. So eventually you might have problems.
Right.
Today, Dr. Matt Skoblar is in Long Island learning how to do endoscopic surgery.
Is he really?
So he's going to start doing these procedures together with me.
Oh, great.
He talks about they're mentioning my name up there as far as certain ways of doing the procedure. You have a unique way of doing it based on the fact that I've studied how to do it all over the world right from the beginning.
Right.
I went to Korea, which is unbelievable, Germany, France, Holland, South America, all over Europe.
I was going to say earlier when you were talking about how they didn't know what it was. There was no name for it, and then but you were the one that was there, and you followed. You really helped build what it is today.
Well, that's true because when I started, there were already a bunch of guys doing it for years, maybe 10, 15 years.
Yeah.
But they just went in the disc and decompressed it, really. Very few people were coming outside the disc, and that's where the problem is. When you have pain, it's usually, you can have discogenic pain. However, the discogenic pain is from the disc, and a lot of times that it helps you when you go in the disc and treat it.
Hmm.
But that's a very small percentage of the pain coming from the disc. You got bulging disc, protruding disc, extruding disc, sequestrated disc, which means that they keep getting bigger and bigger, and usually put pressure on the outside of the disc, like the neural structures. For example, exiting nerve root, the traversing nerve root, the dura. Even the discs become, the annulus is painful, right? And you got to relieve the pressure. That's what it is. What's called decompression.
Yeah.
Tubular decompression, it's called, and that's what we do. And that's what Matt's learning how to do now. And he's been studying all week, and he's been asking me questions based on what he's studying.
Right.
A couple of times he didn't realize that I should actually write my own book on it, but he's reading books other people wrote that are probably not as experienced as I am in doing the case. In fact, he texted me this morning and said that they were talking about how they take down like the end plate, which is you need to know the anatomy. And he goes, somebody just gave a lecture on that. The guy teaching said somebody just gave a lecture on that last week. However, Gabe does it all the time.
Right.
Been doing it for years, so they know me. Anyway, so we do epidurals.
Yeah.
We treat the arthritis of the spine. We take care of every joint as far as injections. We do regenerative medicine, with stem cells, but not necessarily stem cells. That's a controversial statement.
Yeah.
Because stem cells don't really exist on the outside world. The only way you can actually use stem cells is if you have to retrieve it from the person's body.
Right.
And then you can use their own stem cells, which is perfectly legal. And you can use the terminology, we're going to inject stem cells because it's their own homologous stem cells that they get from the patient's body. You can't really get it from anybody else.
Right.
Where it has to be treated, and usually when you treat it, it kills it. But so we give steroid injections in the joints. We do shoulders, rotator cuffs, hips. We do arthritis of the hip. We have torn labrums, torn tendons of the shoulder, also elbow, tennis elbow,
right.
Carpal tunnel injections we do. I was considering actually doing carpal tunnel release. It's a very simple procedure.
Really?
But I got a lot on my plate. Let the hand surgeons do that.
My grand suffered from that. And man, it's amazing what they have now,
Yeah, that's just part of the things that we do. Now, one thing I don't talk about, it's kind of going to be the topic of the day today, is it's about how we treat the cervical spine. What is the cervical spine? It's the neck.
Right.
The spine starts at the base of the skull. Spinal cord goes all the way down right through the cervical spine, which is the neck, thoracic spine, which is in the thoracic area, the chest area. And then you got the lumbar spine and the sacral spine. The spinal cord ends usually in the lower thoracic area or upper lumbar area, depending on the person.
Right.
And from that point on, you have the cauda inquina, which is equina means tail. Cauda means tail, and equina means horse. So it's a horse's tail. So it looks like a horse's tail.
I really like that.
So all these nerves come out of the spine through the neuroforaminus, through the holes, and they go to innervate. A little bit technical terminology. They go to give sensation or get sensation from parts of the body and give motor function to make you walk and stuff like that.
Yeah.
But the neck, the neck is a little bit more intricate as far as intimidation goes. Not too many doctors like to work around the neck. Why? Because you have the spinal cord up there. It's close to the brain, a lot smaller. The spinal cord is a lot closer to where the epidural space.
Yeah.
The spinal cord is pretty nice size up there. The neck moves, whereas the lumbar spine does not move that much. So sometimes you have a moving target when you give injections. But in that area, patients could have different types of symptoms. And I hope people are out there listening to the types of symptoms that we can treat.
Right.
especially people have this crispy, crunchy crackling of the neck when they move their neck. You can sometimes hear it across the room.
Right, right.
That's arthritis of the facet joints, which you get also in the lumbar spine. But it's usually more prevalent in the neck, especially if you're genetically predisposed to have it, like myself.
Right.
Everybody has it in my family, but thank God not to a bad extreme. And then you have another, and that's called spondylosis, which is a fancy name of saying arthritis in the neck.
Right.
And that's very treatable. We treat that with radiofrequency lesioning, and some people inject directly into the joints. We used to do a lot of that, but we found out that there's a little nerve that comes out of the joint that brings pain sensation to the brain. In any facet joint, zygohypophyseal joint, whatever you want to call it, we got it in the lumbar spine, thoracic spine, and also in the sacrum, and also the cervical spine, which we're talking about today. That kind of pain is mostly pain in the back of the neck. It gives you stiffness, pain on movement, extension, flexion, left and right lateral rotation,
Right.
because of the arthritis. And it gives you decreased range of motion. Like I can't even look up because of the severity of my arthritis, but it doesn't bother me that much. You learn to live with it most of the time. But sometimes it'll give you spasms, just like in the lumbar spine, it'll give you spasms in the back of the neck. And it gives you spasms into your trapezius muscle and the part of the shoulder,
Right.
and into the upper part of your thoracic area. And you might not think that it's caused by neck. You think, I had a patient come in the other day, my thoracic area, we need to do an MRI of the thoracic area, but it wasn't. It was pain coming from the neck, from the cervical area. But we do diagnostic injections to make sure that it is coming from that area. And if it is, we treat it with the radiofrequency ablation. If anybody had that done, we do that. But you need to understand that we're limited to what the insurance companies allow us to do when it comes to that.
Yeah.
For example, they only allow us to do 3 nerves on each side. And each joint is innervated by, in other words, each joint, the pain sensation from each joint comes from 2 nerves.
Right.
So if you're only doing 3 nerves, you're only treating 2 levels. And there are patients out there there's 7 vertebrae. So you got 7 to 8, sometimes 6 levels of arthritis. So they go to other doctors, and the doctors treat what the insurance companies pay for, and then they forget about it. And sometimes the patients don't even go back, because you're going to get 2 tests with local anesthetic,
Right.
every 2 weeks. So right there it's like a 2 weeks right there you lost with 6 injections in the neck. And then they do the 3 burning of the nerves bilaterally, and the patient really doesn't get much better, maybe 5-10% better. So they fly the coop, they go somewhere else, and they come to see me. And they tell me that's what happened. And I look at the MRI, I say, you know what? You have arthritis above that area. So now you do 3 other levels above. Now you're covering at least 5 or 6 joints. And then they get tremendous relief. They might be 60 to 80% better.
Right.
I don't know why. Hopefully I'm not letting the cat out of the bag here, but good, educate some of these physicians that you need to do all of them. And patients don't want so many injections, but you got to talk to them, not talk them into it, but you got to explain to them what their options are and the results. So that's how we treat arthritis. And arthritis has been around. The ablation of the medial branch nerves have been around for 20 years. And it's been very successful. Insurance companies still pay for it. And why? Because it works.
Yeah.
But now the more serious problem that we'll get into, because most people can live with arthritis in the neck, just limited motion, pain. But what happens is some patients have what they call radicular pain. They have pain that you feel in the base of the neck, radiates down into the shoulders, down into the arms, the upper arm, the forearms, and it goes all the way down into their fingers.
Right.
And it's a pressure on a nerve coming out of the spine. I don't have a model with me, but it's a pressure of the nerve it comes out of the cervical spine somehow. Could be a bone spur, could be a herniated disc, it could be some type of foraminal stenosis or central canal stenosis, which is putting pressure on this nerve that innervates it could be the pinky, could be the thumb, or anywhere in between.
Right.
It doesn't even have to go down to the hand. It could go down to the forearm, depending on how bad the pressure is. That's called radicular pain. That people don't understand. They think it's coming from the hand. They think it's coming from carpal tunnel. They think it's coming from some pinched nerve in the elbow, which could be.
Yeah.
But if it's radiating down, that's coming out of the neck. And probably, listen, in my practice, I never did an official study, but I'd say 80% of the people do well with just a cervical epidural, simple cervical epidural.
Right.
And I'm not talking a series of 3 cervical epidurals.
No.
But if you go to a physician like myself and you got a herniated disc, which is causing severe pain going down your right arm, and not only that, weakness. The typical symptom is people say that things drop out of their hand.
Right.
You know, I pick up a cup of coffee and it drops. Pick up a glass, it drops. Anything. They have trouble buttoning their shirt.
Yeah.
Right. Of course, you got to make the differential diagnosis of carpal tunnel, of course. But this is when it becomes serious. And if you don't act on it right away, it could be permanent because it's pressure on this nerve. And at our facility, we treat every day. We treat people with cervical, radicular pain, arthritis, and we do the cervical epidural. It's pretty simple. And you know, depending on what level, you make a decision and you use certain types of medication. And we do not skimp in our practice. We use the most expensive, best quality, and most effective medication. That's why a lot of times our shots work and other people's don't. So if you had a cervical epidural in the past and it really didn't work, you know, for some reason, and this is the truth, it happens all the time, and you probably heard it yourself. Patients come to my office, like I had one yesterday, said, "Doc, I could show you all my papers and records that I've had these injections before."
Yeah.
And then the first question they ask is, "Why are you giving me the same injections?" And we talked about this on the show.
Yeah.
The second question they asked me is, "Why did yours work and theirs did not?"
Because that's the big thing. When I was a patient, bouncing around from doctor to doctor to doctor, I used to think the same thing. Like, and then as soon as they said we're going to start off with giving you an injection, my eyes started to roll because I've had thousands of injections and none of them worked.
Yeah. So we can't. I always say, listen, you got to, and we talked about this, and it's important even in the cerebral spine.
Yeah.
We use medication that a lot of other doctors don't use. I'm not going to mention the brand here,
right,
but this is not, you know, I'm not trying to push any
products or anything like that. Yeah.
But, and it's also accuracy. You need to put that needle in the right spot.
Yeah. And
I'm talking not even less than a millimeter. It's got to be right there. If you're a millimeter off, it's not going to work.
Yeah.
You know, that sounds, well,
you told me a story once about training somebody to do,
endoscopic. Yeah.
Yeah. And he's
not
like,
just somebody, a lot of doctors.
And he's like, "How's that?" And you were like, "It's great. It's just, you're nowhere near where it needs to be, you know?"
Yeah. And I give them, when they come, normally they don't pay for the course because the companies usually, you know, sponsor the courses.
Right.
They would like them to use their instruments. But, you know, they pay me, you know, that's my disclosure. They pay me to teach these guys, you know, because I take time out of my personal life and I take time out of my working life to do these things. Of course, I enjoy teaching.
Oh, yeah.
But I'll tell them, I'll give them one shot. If they get it in the wrong spot by putting a needle in, and I'm talking to doctors been putting needles in for 10 years, some of them 15 years, 20 years. And I say, I'm going to give you 3 shots at this. I'm pretty generous.
Yeah.
If they can't get it in one shot, there's a problem.
Right.
If they can't get it in 3 different attempts, I'm not nasty about it, but I'll tell them ahead of time. I said, we're done here. You're not going to learn advanced endoscopic, minimally invasive spine surgery if you can't stick a needle in.
Yeah.
You know, and you know what? It's not only the interventional pain docs who are trained to do this. I don't know how they pass their courses if they can't do it, but it's also the surgeons. A lot of surgeons like to learn how to do this, smart ones.
Yeah.
and the ones that have enough time to do it. But it's the future, so they need to learn. And they're not trained to put needles in. So I'm lenient when it comes to them.
Yeah.
You know, I because part of their course is learning how to put needles in.
Yeah.
You know, but there's no excuse for an interventional pain doc puts needles in patients every day.
Right.
What does that tell me? That it's not going in the right spot. And that's the topic of this conversation right now.
Yeah.
Why do my injections work and others don't? Because we have redundancy too. You know, we put a dye in there and make sure it flows the right way.
Yeah.
But and somebody puts dye in my OR, everybody knows where it's supposed to be. So if you happen to be in my OR and you're putting a needle in and it doesn't go where it's supposed to be, everybody knows that it's not supposed to. And they'll tell me that you didn't put it in the right spot.
Right. Right.
So, you know, you got to put it in the right spot. Now, when I say 80%, this is a general figure. I'm sure there's more statistics out there, but and it might be even higher in my practice because I don't send too many patients out to get major spine surgery of the neck. However, there are some patients that need it. You know, you give them one epidural, it gets 50% better. I might give them a second one. If they come back and they're only 50% better the second time, or now getting worse again, there is nothing I could do to get that better.
Yeah.
You know, I mean, I've learned how to do endoscopic surgery of the spine. It's almost like there's so little of that going on because there's so little that isn't treated by injections of the cervical spine that I don't have enough patients to practice on to get real good at it. So occasionally I go take some courses, I do them on cadavers, and it's relatively easy. You know, and you know, if there's an increased run of patients that have cervical problems, I'm going to probably start doing it. But I know great surgeons. Some work at my office, and some don't. Patients want to go to their own surgeon.
Yeah.
But I'm the one that can diagnose it.
Yeah.
You don't need to go to a surgeon right off the bat because you have neck pain or you got pain going down the arm. Because I will never deny a patient an epidural injection if you got a pinched nerve in the neck. Why? Because when the nerve shrinks down to normal size, even if there's a herniation there, that doesn't mean you need surgery.
Right.
If all the symptoms go away, and that's the majority of the patients. So you need to come to somebody like me, you know, to make the diagnosis.
Yeah.
And I'm the first one to tell you that you're going to need surgery. In fact, we had a patient yesterday that came, an older patient. No, it wasn't even older. She was 54 years old.
Oh.
And she had moderate to severe central canal stenosis. Now, this is very, very important. This is a very serious matter here because you end up in a wheelchair. This lady, you know, she's a little overweight, you know, so that doesn't help.
Right.
Especially when you have central canal stenosis of the cervical spine. Now, this is pretty technical, what I'm about to say, but some people out there might have these symptoms, and they think it's coming from the lumbar spine. Some doctors don't know how to make this diagnosis. But if a patient has really no pain down their legs and minimal pain in their back, but they're stumbling around, like she said, the husband said she fell down the stairs in the last 2 months 5 times.
Yeah.
Why? Because when you have stenosis of the neck, you see, we have different types of nerves coming out of the brain.
Right.
To keep it simple, we have motor nerves. They're very thick, and they have insulation on the outside of them, so they're protected. So the electrical impulse, because they're thick and strong, very little will stop them from working. You know, shy of cutting them.
Right. Right.
You could have severe spinal stenosis, but you could still move your legs. However, the nerves that go from your feet and your legs to the brain that tells your brain where your legs are, where your feet are very fine nerves. They don't have insulation on them.
Huh.
And they're very sensitive to pressure. So you put a lot of pressure on, especially a lot of pressure, they slow down tremendously to the point where if you could be walking and you move your right foot in front of the left foot, by the time your foot is there, right? But when it's there, your brain thinks it's still back behind the left foot unless you look at your foot. So this is a test for the people listening at home. If you have trouble some people don't even realize that
Yeah.
they feel like they're drunk.
Yeah.
They don't really know where their feet are. In fact, this lady's smart enough to say that I got to look at my feet. How does that get rid of that sensation of not knowing where it is? Because your eyes see your feet and register in the brain a lot faster than that nerve will where your foot is.
Yeah.
So that's kind of a test, and people could do this at home.
When I was at my in-laws, and I was all, in pain before I met you and stuff, it was like early days. I was still dating Maggie and that, and we were leaving, and she had like a little, like 2-inch lip. You got to step down from the front door into her patio. And I stepped down, but I thought my foot was where it was supposed to be, and I face planted right down. And yeah, I mean, it's 100%. What you were saying was exactly.
But that's more normal.
Yeah,
that's normal.
Yeah.
Why is that normal? Because that's why I'm not a carpenter,
right?
But I know enough about carpentry work and building a set of stairs that you have to have it build. You have to build it to specs,
right?
Because stairs have to be the same height, right? Because we climb upstairs all the time.
Yeah.
And if there were different heights, and believe me, if you have a step that's a different height, you're going to find out, even if you're normal. You lift your foot up without looking, and if the step is 1 inch higher, you're going to catch it and fall.
Right.
Or almost fall.
Yeah.
Now you had that little step on the bottom. You don't know it's there. You don't think about it there all the time. And you're going to trip on it. That's normal stuff. But what I'm talking about is your brain doesn't know where your feet are.
Right.
So the test is at home. If you think you might have this problem or you suspect spinal stenosis, look at your feet when you walk. If all your symptoms go away, it's spinal stenosis of the neck. And I do this test all the time when I suspect. In fact, the nurses now know how to diagnose this.
Yeah.
And we send the patients for a cervical MRI. Sure enough, this lady had 2 levels of moderate to severe central canal stenosis, mostly moderate. It was severe, she'd probably go straight to the surgeon. Now, what I do is I at this point, she didn't have any what they call myelomalacia. Myelomalacia is when they put so much pressure on the spine, it actually starts to break down the center of the spinal cord. And that's a big problem. Big problem. The spinal cord starts to die. You'll become paralyzed. That's almost an urgent situation where you need a surgeon to decompress it. I'm not going to decompress that. I can't do that. I'm not trained. A man's got to know his limitations.
That's right.
And I'm not trained.
Yeah.
That's when you got to go to a surgeon, a good cervical spine surgeon. I know them.
Yeah.
We have a good one in our office, Dr. Radcliffe. He does a fantastic job. And there's a couple other surgeons that, you got a choice, I can't force you to go anywhere, but it needs to be decompressed. However, this one, the lady that's tripping all over the place, if she doesn't have myelomalacia, white specks in the spinal cord, I'll do a cervical epidural and see how she does. And I've done quite a few of them where you can buy some time. They're going to become probably more stenotic as they get older. But if we can clear up all her symptoms, we can get her ready to prepare herself mentally, at least,
right,
to get the surgery. And it's almost inevitable you might need the surgery. Now, if I get a person that comes in, I had a patient that came in at like 90 years old that had the same symptoms, and they're using a walker, right? If they did spine surgery on that patient, how much better are they going to be, right? And is it going to get any better, because it might be to the point of no return anyway.
Right.
And it's high risk for somebody at that age, not when you're young, and not even even if you're 80 years old, a good 80-year-old, 85-year-old, even a good 90-year-old. There's some good 90-year-olds out there that if you need it, you need it.
Yeah.
But you got to weigh the risks and benefits. And if you give that person, a 90-year-old person, an epidural, and all the symptoms disappear, just like a younger person, you wait. There's no rush.
Yeah.
You go for a consultation. You maybe put a surgeon in the loop. But what we do is we treat anybody have any problems with the neck. Don't think that we don't treat it.
Yeah.
I mean, this is probably 50% of our practice. is treating anybody with neck pain, shoulder pain from the neck, and even shoulder pain from arthritis and rotator cuff tears, and pain rate, especially radiating down into the arm,
Yeah.
weakness in the arm, weakness in the hands and the fingers, numbness and tingling. Because you can have no pain but just have numbness and tingling, and sometimes with an epidural, that all goes away. If a person has maybe improves 50% with the strength, and they still have annoying pain down the arm, I wouldn't say live with it, because today, and I've noticed that neck surgery, in my opinion, and I'm telling you, I don't do much research on this.
Right.
I just don't have time. But in my own, I've been doing this for 27 years, pushing 28 years, and I could have my own statistics, just off the top of my head, which is pretty accurate.
Yeah.
But the majority of the people who go for cervical spine surgery, especially when I send them,
Right.
and I communicate closely with the surgeon, it's close to 100% successful.
Yeah.
With very little downtime. It's not like going for major lumbar spine surgery, which I, in my my practice, avoid that almost at all costs.
Yeah.
But when they need it, I'm the first one to say they need it.
Yeah, you always do say that.
I'm not stupid like that.
Yeah.
You got to know when and when not to.
Yeah.
And guess what? As time goes by, there's less and less spine surgeries, open traditional spine surgeons. And these open traditional spine surgeons, like Dr. Radcliffe, he's learning how to do endoscopic surgery. He's learning how to do the minimally invasive stuff. He already does his own minimally invasive stuff that he's learned.
Yeah.
And he concentrates on that before he does anything big and life-changing type stuff, whether good or bad, So that's my neck.
I gotta tell you, man, like, you blew my mind, man. You were saying some stuff. Like, that's the cool thing about Doc, is that just when you think you've reached this seemingly bottomless well of knowledge, you realize that you haven't even scratched the surface.
What stimulated me today, I got to give him credit, Ryan Clark.
Oh yeah,
yeah. He said, talk about necks. You do a lot of neck stuff. Talk about what you could do to the neck, because there's a lot of people out there he knows that needs neck, and they don't know where to go.
Yeah.
And if we could capture them into our facility, we could help a lot of people, whether it's just, minimally invasive, non-invasive, even physical therapy. We don't do physical therapy, but we know where to send you.
Yeah.
And to the point where if you need surgery, we actually do that in our surgery center now. I did anesthesia for spine surgery on Thursday. Wow. Patient did fantastic. Anesthesia-wise, did great. And we're capable, and I'm capable of doing the general anesthesia for people like that. And we talked about this with Dr. Radcliffe on the not quite awake, but the closest you could be awake for certain surgeries. Like when they're working in the neck, it's a very small area. It pretty much got to keep that patient still.
Yeah.
If they were awake, it'd probably be a little bit uncomfortable. And sometimes you got to sedate them to the point where they don't understand, and they become crazy. So you got to know
the balance,
do the anesthesia. Right? And it's all, we don't use vapor, gases anymore. We use what they call TiVo, which is total intravenous anesthesia. And it works great. Patient wakes up, awake and alert, ready to go home that day. So we do great stuff that I don't know if too many surgery centers do that kind of stuff. Most of the time they like to do them in the big hospitals and with all kinds of support, but done minimally invasively with good anesthesiologists. It's very easily done in the surgery center, and that's what we do.
Yeah. Well, Frank over here says, Dr. J, you're the best. And I got to agree with him. The stuff that Dr. J knows, it's just mental. It's so much stuff. All those words you were talking about, and like the nerves.
I made most of them up.
You made most.
No, I'm just kidding.
No, but like the nerves and those, the mobile nerves and stuff. I who knew that you would know all that and all the terminology perfectly and all, you know, all that stuff. You were throwing words at me
Well,
I'd
you know, it's
never heard you
amazing. A
say.
lot of the doctors don't even know that concept. I mean, if you're good, you're good.
Yeah. Yeah.
But it all comes down to training. And I talked about this. I remember when I did when I was doing my surgical residency.
Yeah.
I was doing my surgical residency, and I was transitioning into anesthesia and pain. So it was the end of the year of my surgical training, and there was a bunch of us outside. They had students at the hospital, and the students already left to go home. And there was one particular student, nice person, said, "Listen, they gave us apartments because they came out of Philadelphia. So they gave them little apartments on the premises of the hospital for the students." And she was like, "Here's the keys to my apartment. You know, the guys have fun because we used to have like little parties on a Friday afternoon, and they had weights there. We would weight it and have a few drinks and the music going. We were having fun. Invite our girlfriends and stuff like that, and they'd come over, have little parties. You know, socialize, get to know each other."
Yeah.
Well, one time I'm sitting there having a beer.
Right.
I just finished working out a little bit, and there was a aspiring anesthesia resident just finished his 1 year internship, and it wasn't surgery; he did an internship in medicine, and then the last rotation was a rotation in anesthesia because that's what he wants to do,
Right.
and he's sitting there with a patch on his arm. I'm like, "What is that for? You know, why do you got a patch on you?" I'm naive; I don't know about this stuff. He goes, "It's a fentanyl patch." I said, "Where the hell did you get a fentanyl patch?" He goes, "Well, my job today was to change the fentanyl patches on all the old people on the floor."
Right.
So I went in and I didn't change the patch. I just kept it. So now you have every 72 hours, you got to change a patch. Otherwise it doesn't work.
Yeah.
So now you got who knows how many he took. Right. And how many people now for 72 hours going to suffer without
My
pain?
God.
I mean, you know, it sounds funny, but it ain't
It's
funny.
not funny. No.
And I was like, "What are you, nuts? That's a narcotic. That's the most potent narcotic on the market today." He goes, "Yeah, what do you think I'm going into anesthesia for?"
Oh.
Now, that was 1993.
Wow.
Right? It was 1993. I can't remember what this guy's name is, and I've talked about this on the show. And the guy had this look at his eye, and he goes, "Why do you think I'm going into anesthesia?" I bet you that guy's is dead today.
Probably. Yeah.
Those are the people who die. They die of overdose. He had access to fentanyl. There are stories about anesthesiologists, residents, that they found them dead, shooting up in their main vein.
Oh,
in
my
the
God.
bathroom, dead. Right, overdosing on it. I don't know why you would overdose on it. You're an anesthesiologist. You know how to dose that stuff.
You should.
But most of them don't die right away, but
Right.
eventually something happens. And so in fact, when our first day of anesthesia residency, we had a Dr. Akhtar, nice guy. He was a new attending young guy, and he gave the lecture about drug abuse with anesthesiologists. You know, and he said, he goes,
So it is a real common thing.
He's the most common specialty, he said at the time, who knows what it is now, was where they abuse drugs would be anesthesia.
Wow.
Why? Because it's the easy access. You know, so if you're a real drug addict, that's what they go into.
Temptation,
you know,
right?
It's like a pedophile goes into somewhere where they have, kids.
Working as a janitor in a preschool.
You know,
something like that.
You got to watch out for things
You got to watch out.
And I've heard some stories of friends of mine that had told me stories about they'd had a party and they found a guy, an anesthesiologist, in their bathroom dead the next morning.
Oh shit!
You know, and they all got in big trouble for that. But they were talking about, you know, how to avoid it, you know, how not to get involved. If you're even thinking about doing something like this, seek help. And they even talked about even if people do abuse it, they don't just fire you. They have to seek treatment for you because they consider that a disease. Just like
sickness, right?
Alcoholism, drug addict, that's what it is, a drug addiction.
Yeah.
that's another complete topic. And
Yeah, that's fast. It's crazy to know. Yeah. Wow.
I mean, we always get something new.
Yeah.
You
Yeah.
know, there's a lot of same stuff we talk about,
Yeah.
and I talk about it because you got to drive it into some people's brains on what we do.
Yeah.
And they don't understand. I got patients that are my patients for a year, and then they come back 2 years later with surgery of the neck. And I'm like, what? Why did you get sick? How come you didn't come to me? Well, why do you work? Do you do that kind of stuff?
I remember the person that actually said that to you because you told me this story. Yeah.
Well, there's a lot, but now I'm sure I mean, if they could. But you know, the worst part about it is I was like, well, how come you didn't mention anything about your neck? Because I didn't know you do that. Well, you know, you come to me and I say, what pain do you have?
Right.
Well, leg pain. I might not say, look at you in the eye and say, you sure you don't have any neck pain?
Right.
You know, you got to tell me what kind of pain you got. Like another funny guy comes to my office yesterday and he goes, Doc, I have numbness in my leg. And I said, no pain? He goes, oh, I have absolutely no pain. Never had any pain. I said, did you see the sign on the door? Pain doctor, not a numb leg doctor.
Yeah.
I mean, I try to make him laugh, but it's true. We treat numbness because it's for the same reason. You have a pinched nerve.
Yeah.
But this guy had severe pain at one time, and you're talking 2 years ago. He had severe pain down his leg, and we managed to get rid of it.
Yeah.
He's got spinal stenosis. He's got foraminal stenosis, and I could get rid of that numbness. You know, I can make him walk better. But this guy is like, 85 years old, in good shape. And he says, Doc, I can live with the numbness because we give him a medication, and I'll talk about this medication. It's called gabapentin.
Oh, yeah.
Neurontin. And it's a very good medication to treat nerve pain.
Yeah.
And
I take that.
Dysesthesia.
Yeah.
Hyperalgia, all these different terminologies that are pain or symptoms, numbness coming from a nerve. Right. And he says he takes he says he gets most of the numbness at night and he can't sleep. During the day, he's okay. He doesn't even notice it. So he takes a very low dose of gabapentin.
Yeah.
And pain goes away, sleeps nice.
Huh.
It's a sedative to a certain extent. It's not a narcotic. And I have quite a few patients on that. Not the majority of my patients. In fact, probably you count on one hand, 5 fingers or less, the patients I have on it, because sometimes you need to just calm down. And it could be from the central nervous system too. It doesn't have to be from an actual pinched nerve.
Right.
It just calms down. I think at one time it was an anti-epileptic, so it just calms down nerves, like the brain. It calms it down so you don't have seizures. But I had a patient that came to me yesterday again that actually did pretty well on gabapentin. It was a new patient, and the nurse gave me a report and says, Dr. So-and-so, the podiatrist, threatened him and said, if you ever go on gabapentin again, I'm discharging you as my patient. Huh. How unethical is that?
Yeah.
You have a FDA-approved medication with very few side effects that actually works. He told her that never works. All it does is hurt you. Maybe he had a personal experience with it,
maybe
with him or his family member, where, with any kind of medication.
So that particular doctor's experience verged off into a different direction.
I'm gonna discharge you as a patient.
Yeah.
So now the patient comes in with a closed mind about, not that I, plan on prescribing it, because when I saw the patient had herniated disc at one level. I'm going to give them an injection. Chances are the pain's going to all go away. If not, I take the herniation out.
Yeah.
And they don't need to go on gabapentin. But just to hear
that's got to be so powerful to say, though. If not, I'll just take the herniation out. The stuff you do, man. It really,
it's very satisfying.
Yeah.
It's very satisfying. And also, but a lot of times it isn't very satisfying, because you'll get a patient, no matter what you do, nothing helps them.
Nothing helps them, yeah.
And you got to be careful with those patients. We had a patient, Dr. Scobler had a young patient that had a herniated disc and had a percutaneous discectomy done by another doctor, who, by the way, I called the doctor and left a message to talk to him about the patient, never got back to me. So I don't know whether they're nervous to talk to me or anything, but I think what he did was right. Young patient, did what they call is they gave him a pseudo endoscopic procedure. It's not endoscopic. It's a glorified percutaneous discectomy. It's all done under indirect visualization, and they just decompress the center of the disc, which in a patient like that could work tremendously.
Right.
It's indicated to do that on that patient, but the doctor books it, and he thinks, and the company that sells the instrumentation think that it's perfectly okay to code that as an endoscopic discectomy, which it isn't.
It isn't.
What they do is they stick the scope in after he's done indirect visualization, which means you're looking at a monitor under X-ray, so it's not direct. Like when I do endoscopic surgery, I'm looking at the monitor and I see through the camera and the lens on the end of the camera, I see everything clear as day.
Right.
This, you're doing it all indirect visualization, looking at the X-rays, and then they stick a camera in there, a scope, and then they take a picture. Now that's endoscopic. No, but it's a great procedure with a patient that has.
What a loophole.
Yeah, and that's what ruined it for endoscopic surgery. I hate to say it. The guy who invented it and put it out in the market, I love the guy. He's a genius. He's a marketing genius.
Right.
Making millions of dollars on that, and they're still getting away with it.
Huh.
And I'm not mentioning any names. I'm not sure what it is.
Sure.
However, it's a great procedure on a person that has contained disc herniation, less than 6 millimeters.
Yeah.
Right. You go in there, you decompress it, and it's like taking air out of a tire. And a lot of patients, probably 70, 80% of patients do good. Now, this particular patient didn't, and probably needs an endoscopic surgery to decompress, to actually get the herniation out of there, get it off the nerve. Right. Very simple procedure. And when I talked to the patient about the surgery she had before, she said she wanted to sue the doctor. I said, first of all, the doctor did nothing wrong. Right. In fact, you should thank him for doing that, because you're young, and that's what it's made for, somebody like you.
Yeah.
You know, and even anybody else that has a contained disc less than 6 millimeters, that's the way to go.
Yeah.
I do it endoscopically because it's only, 3 millimeters bigger, and it's under direct visualization. But a lot of doctors don't know how to do endoscopic surgery. It's a difficult procedure and long, drawn out learning process, very shallow learning curve, right? Whereas the one that he did is very simple. You do one, teach one kind of thing. It's a surgical jargon.
Right.
It's not easy. It's not very steep learning curve. You do one, you learn one, do one, and teach one. So it's very easy to learn and safe. And that's the best way to go for somebody like her. And I told her, I said, he did you a favor. It would have been better if it worked, but it didn't work. Guess what? Now you go to the next minimally invasive procedure. You do not need open surgery for that. But if she goes to an open surgeon that doesn't know how to do endoscopic surgery, they'll open it and do maybe a microdiscectomy or a hemilaminectomy or something like that. But if you go to one that's a little dishonest, they'll do a fusion.
Yeah.
So that's it. You got to be careful with that. So there's a lot of good. In my office, you see walks of all life coming in, and we could talk all day, all week on different scenarios that come into the office just to get people to know how they can be treated properly.
Yeah. I mean, a different doctor might have used that situation to say, oh, that guy didn't know what the hell he was doing, and then talk themselves up. But it's crazy. You started the show by claiming that you were the master of pain, but you were still humble at times, where you will not break that code of yours, where you have to be honest. You always do right by your patients. And that is the number one reason why I stuck with you all these years.
I mean,
because of that character,
Listen, if I honestly know a doctor that is dangerous and hurt people, I'm not gonna go and well, I guess technically I should report them to the State Board of Medical Examiners.
Yeah.
And there's not too many doctors I know like that.
Yeah.
So that being said, there are some doctors that I just, feel are not equipped with their hand-eye coordination and their diagnostic skills to send any of my patients to.
Yeah.
Right. But I'll never really say anything bad about them.
No.
If they ask me, say, what do you think about this doctor? I'm going to go get this, this, and this. And I'll tell them the truth.
Yeah.
I'm not going to, it's a fellow, it's a, physician. I'm going to hide the truth. No,
Right.
I want my patients to do well.
Yeah.
So, I don't bash them. I don't bash doctors. And some doctors love to bash.
You never
other
bash doctors. In fact, even if you get angry about them, you will never bash them.
I don't know. I bashed a few doctors.
I've never heard you. I've never heard
some
you.
of the doctors.
Very,
of the doctors that talk out their, what?
Oh yeah.
Well, I can say that.
You can say
out their
yes.
ass,
Yeah. We're not on the radio.
right? And they tell patients that what I do is bogus.
Yeah.
And hocus pocus.
Well, that's what I was going to say, because other doctors have done that to you.
Yeah.
Yeah, where they've talked you down and them up,
I mean, there's a couple doctors, and I'm not going to mention their names, but there are doctors out there that will work and just all they do is they do procedures so they could fail that they get from surgeons and then send them back, and it becomes a vicious cycle.
Right.
Where they get patients, they fail, they get surgery, they get more patients. I'm not even calling them interventional pain docs. There are doctors that are injection guys that just give injections, and they don't know much about the anatomy. They don't know much about anything. They just give a simple series of 3, not necessarily even in the right place.
And send them off to
you put it
physical
in
therapy.
the right place, it might work.
Yeah.
We had a patient like that the other day that, they give them caudal injections, and they got a problem at L3.
Right.
That's 3 or 4 spaces away, vertebral bodies away. It's far away. And the nerve is being pinched coming out of there. Give the shot right along the nerve, shrink that nerve down, decompress it, decrease the inflammatory process, which decreases the swelling, decreases the pain. Not stick it in the patient's butt and think it's going to work.
Right.
That's basically what you're doing. At the base of the tailbone is an opening over there. And they still teach doctors that. They still teach doctors that. I don't know what they're thinking.
Right.
It must be too many. I got too many years of experience.
That's it.
Like Matt was going over. He says, "Do you think this neuroforamen is too tight to stick an endoscope in there? Because I've read some chapters that you're not supposed to do it." Well, no, you're not supposed to do it if you stick it into the disc. Right. You want to just jam it through there and stick it into the disc and just work in the center of this like most of these guys do. But the problem is right there where the nerve is pinched that you can see on the MRI. That's where you work. You decompress it there. That's the indication for it. When it's tight, you open it up and the pain goes away. So, you can get misled in different directions based on people inexperienced that love to write books.
Right.
Right. All right. What time is it? We run out of time now.
Yeah, we're coming.
We got about 4 minutes.
4 minutes.
Take a
Yeah.
little drink.
Yeah. And it's interesting though how like living long enough to become the mold, become the gold standard, and that's what you've become. You've seen your field in its infancy, and you've grown with it, and you've built upon it. Like that's a legacy that you're going to leave behind, man. That's like huge.
I wish I had the time,
Yeah,
and the knowledge to actually write a book.
Yeah. Well, you have the knowledge.
I'll write 2 books. One on, well, you know what? It could be 3 books.
Right.
One on endoscopic surgery.
Sure.
The evolution of it and how it progressed to today, and different steps and how to do it, and different ways of getting around things that help the patient, and bleeding, stuff like that, intraoperatively. I want to write one on the evolution of pain from when I started.
Right.
And then I want to write a book about myself.
That's the one I've been telling you for years.
But I got to hire somebody to do that.
For years. I have always said Doc could write a book, and it may not have anything to do with
Jimmy
medicine.
Fallon.
Yeah.
They had, I like to watch the show sometimes. They had what's the guy that advertised, the actor that advertises for Cadillac? McConnelly.
Oh,
What's his name? McConnelly. He's got the beard, little scruffy beard, thin guy. Very good actor. I like him.
oh, that guy. Yeah, yeah. He
Yeah.
always looks like he just got out of a fight.
Well,
Something like that.
no, I mean, he's got a scruffy little beard, but
Yeah, yeah.
skinny guy, but a good actor. What's his first name? I'm sure somebody will know. Probably could send it to us. But his big thing, he wrote 2 books, and Jimmy Fallon was advertising it, pushing the books. And one was a book about for kids, with pictures and everything, with a cover with a treehouse. And then he wrote a book about himself. And he said it was fascinating. They're starting to, he says, tell us about the time when you built the treehouse, and tell us about the time when you used to drive around with your truck with the muffler and this and that. And you had the CB radio and you were talking with the speaker. And he was talking about this stuff. I must have thousands of stories better than that.
Right.
But you
Dr. Jasper's
who's going to read it?
hijinks.
Who's going to read it? He's Kevin McConnelly, whatever. Who's going to read it? He's got a following. He's an actor.
Yeah.
So people are going to read it and say, that's cool. Who's going to read my book except my friends,
No. I mean, it would be good. I would actually name it Hijinks. Yeah,
What is
Hijinks by Dr. Gabriele Jasper.
Hijinks?
Yeah.
What do you mean?
Because your whole life, you got yourself into one hijinks after the other.
Oh, yeah. Oh, that's what God does. God's sitting around with his buddies with that pond, smoking a cigar, and say, hey, let's see what Gabe's doing. Let's throw something in front of him and see how he gets out of it. Right. That's what Felix always used to say. Felix Vetri, my buddy. Most of the time he was involved with it.
Yeah, Felix was always shotgun, right? Yeah,
he was involved with these daily routine obstacles that were thrown in front of us. All right, so we never talked about where we are. We're at 74 Brick Boulevard, Brick, New Jersey.
Yeah.
You can call me and talk to anybody on my staff. Even you can talk to me if you want. It's 732-262-0700. It's at the bottom of the screen there, 732-262-0700. And we got my website, which is jaspermd.com.
Yeah.
And you can see all of these podcasts on YouTube.
YouTube and Facebook. We archive all of these.
Spotify too.
Spotify, you're going to get the podcast, so you're not going to see the video, but you'll hear the show.
Yeah.
On Spotify, not just there, but on iTunes. Anywhere you can find a podcast, you will find Painless with Dr. Gabriele Jasper.
If you know anybody that has cervical problems, tell them about this podcast. Tell them about, you can go on YouTube, Facebook, and they can, tell them to go over, what we talked about. People don't realize it, especially spinal stenosis in the cervical spine.
Yeah.
If you're walking like you're drunk, chances are you got that. If you fall down the stairs 5 times in 1 month, chances are you got that.
Our president.
The full. Well, you know what? He might. I think he's got more than that. I think he's got Parkinson's disease.
Oh, really?
Listen, I'm not a neurologist, but the way he walks, the way his facial expressions are.
Yeah.
Of course, he had a lot of facial expressions on his State of the Union address, screaming.
Oh, yeah, that was something. That was something. I'm hoping Barb talks about that next.
Probably will. Me, I don't know what to say, but thank you very much, everybody, for listening to me.
Yeah.
And Jeremy, and we're here to help you.
Yeah, we are. Please. For more information about Dr. Jasper and all the wonderful things we talk about on this show, please go to jaspermd.com. Make an appointment at 732-262-0700. Thanks.